Hello, I'm Melinda Stanley, a retired psychologist and emeritus professor of psychiatry and behavioral sciences at Baylor College of Medicine, also a prior researcher at the Michael E. DeBakey VA Medical Center here in Houston. Today I'm going to be talking about anxiety in older adults, part one. This content is brought to you by the Southeast Texas Geriatrics Workforce Enhancement Program, a collaborative program between Baylor College of Medicine and the Michael E. DeBakey VA Medical Center, in partnership with other academic and community service organizations. The project is one of 48 nationwide GWEPs supported by the Health Resources and Services Administration of the U.S. Department of Health and Human Services. Our aim is to improve health outcomes for older adults by helping to develop a healthcare workforce that maximizes patient and family engagement, integrating geriatrics and primary care along with the 4Ms framework to create an age-friendly healthcare system. So thanks for joining today. Let's get started. As I said, today we're going to be talking about anxiety in older adults. The presentation was prepared by myself and Dr. Cynthia Kraus-Schumann, Dr. Mark Koenig. Anxiety is a highly common problem in older people that is frequently unrecognized, undertreated, and therefore an important topic, we think, for providers of older people to be familiar with. So in part one today, we're going to review the symptoms and characteristics of anxiety in older people, as well as some risk factors and other correlates of anxiety. We're going to talk about what anxiety looks like in dementia, now neurocognitive disorder, and then describe some basic diagnostic features and give you an idea of some screening questions you can use to evaluate common anxiety disorders in older people. If I were to ask anyone listening to this talk if he or she had ever experienced anxiety, I would expect to hear an affirmative response from everyone. We've all had anxiety. It's a perfectly normal emotion. We experience anxiety from everyday events like health issues, finances, work, school. We also experience anxiety when more extreme things happen, like car accidents or tornadoes, hurricanes, cold weather, viruses. Anxiety is only, though, a problem when it is too frequent, too intense, it's more severe than is warranted by the situation, lasts too long, it lasts well past the frightening situation. It's a problem if it's difficult to manage, if it feels out of control to us, and if it causes some kind of impairment in work or relationships or enjoyment of activities. If you remember only one thing from this talk, I would like it to be this: anxiety is more common than depression in older people. When we talk about mental health issues among older adults, we often think about depression and are more likely to ask about that, but anxiety actually occurs more often. Anxiety disorders occur less frequently in older adults than younger adults, but that could be partially because we are not too good at diagnosing anxiety in older people. An interesting fact, though, is that across the lifespan, so for both younger and older people, women have more anxiety symptoms than men. So what's the prevalence of anxiety in older people? In community prevalence studies, the rate of anxiety disorders is as high as 10%. If we look at prevalence over the lifetime, it's as high as 15%. Generalized anxiety disorder, which we'll talk about later, is the most prevalent of the anxiety disorders in older people. Specific phobias, social anxiety disorder, and PTSD also are common. It's also important for us to look, though, at primary care prevalence. Because older adults most often present for care to primary care, we want to know how often anxiety shows up in that setting. Among general medical samples of older people, up to 15% will have symptoms that meet criteria for an anxiety disorder. In people with chronic illness, though, which we know happens a lot for older people, as much as a third or more of people will have symptoms that meet criteria for an anxiety disorder. In both of these patient groups, generalized anxiety disorder is the most common. So why don't we recognize anxiety in older adults? What's the problem? First of all, we don't assess. So if we don't assess, we often don't hear an affirmative response. Here are two very simple questions that could be added to a clinical assessment to determine whether there's a need for further evaluation and attention. Over the last 2 weeks, have you often been bothered by feeling nervous, anxious, or on edge? Or have you not been able to stop or control worry? An answer in the affirmative to either of those would warrant some further assessment. Even when we do ask, though, detecting anxiety in older people is complicated based on cognitive decline, perhaps people not being able to remember what their symptoms were like over the last week or 2 weeks. Also complicated by medical comorbidity, we'll talk about this some more a little bit later, the overlap between symptoms of various medical illnesses and anxiety syndromes. And then older adults often use different vocabulary or experience symptoms differently and express the symptoms differently. When we ask older adults if they feel anxious, they often say, no, I'm not anxious, I'm just stressed. If we say, do you worry too much? They may say, no, I don't worry, I just fret, I'm just concerned, I just think too much. It becomes important then to follow up follow up your questioning using those words. So how often do you think too much? How often are you fretting? And how often are you concerned? As you may know from other lectures in this series, we're talking about these issues within the 4M's framework. This is a set of 4 evidence-based elements of improved quality of care for older adults established by the John Hartford Foundation, the Institute for Healthcare Improvement, the American Hospital Association, and the Catholic Health Association. When we think about evaluating and treating anxiety in this framework, we want to, of course, align the plan with what matters to the patient, considering cultural and individual differences in values, beliefs, symptom descriptions. We want to look for common stressors and fears. Older people are most often concerned about health, finances, recent losses. And like other issues for older people, we want to look to the family for support when that's appropriate. We want to consider age-friendly medications and medical problems that may contribute to anxiety or create anxiety-like symptoms. And as always, we want to educate not just patients, but also their families about potential treatment options. We think it's important to include a brief screen, such as the questions we just talked about for anxiety, at some kind of regular interval to be able to detect anxiety when it pops up, and important also to assess for anxiety in individuals with dementia. We'll talk about that some today as well. And finally, we want to think about how anxiety interferes with mobility, physical exercise, completing pleasurable activities. We want to consider fear of falling. And we want to talk about avoidance. What is the older person not doing anymore that they used to do and why? So let's start with what matters. Most important issue here is to be aware of the unique characteristics of anxiety in later life. The topics of concern or topics of anxiety follow a developmental trajectory. Older adults are most often worried about things that make sense for older people to be worried about: health, finances, loss of independence, issues related to aging, fears of being a burden, fear of falling. These are common concerns for older people, but we want to know whether these topics are creating intense, frequent, and impairing levels of anxiety. Older adults sometimes focus more on somatic symptoms than psychological symptoms, so we want to ask about those. We want to consider, as we were just saying, the different words that older people may use to describe their anxiety. We also want to do a lot of education. We're going to talk about that a number of times throughout this 2-part series. Older adults know less about symptoms of anxiety, and there is a lot of mental health stigma in older people to acknowledging symptoms of stress and anxiety. Older adults, as we've said, are more likely to present to primary care providers, so those specialists, those people will be the ones who are the first to hear about anxiety rather than mental health specialists. Anxiety symptoms among older people are important to be aware of, even if the person doesn't meet criteria, even if the symptoms don't meet criteria for a disorder. they still can cause significant distress and warrant some kind of assessment and treatment. It can be a little harder to assess disruption in functioning for older people if the person has no regular work, volunteer, education, partner obligations, but it's important to consider nevertheless. Also important to understand that a history of undiagnosed anxiety or a history of no recognized anxiety leading to current symptoms doesn't mean that there aren't symptoms that need to be treated. So people will sometimes say, oh, I've always been a worrywart. That's just me. That's just the way I am. Doesn't mean that the anxiety is normal and should not be treated. How about the impact of anxiety in later life? Anxiety is associated with a lot of negative outcomes, increased disability and poor health-related quality of life, even when we control for actual health status and depression. Anxiety is associated with increased functional impairment, incontinence, and falling, and associated with higher levels of functional dependence, such as bathing. So older adults become afraid of falling, and then they don't want to do a variety of ADLs. They don't want to bathe anymore. Anxiety comes with increased risk for coexistent depression. Actually, when the two occur together, when anxiety and depression are comorbid, usually the anxiety was there first, meaning that if we get better at assessing anxiety in our older patients, we may be able to reduce the risk for episodes of depression. Anxiety also comes with an increased risk of cognitive difficulties. Anxiety for people of any age is associated with attention and memory difficulties, but anxiety in older people actually increases the risk for dementia. Also increases rates of service use, healthcare costs, and a number of studies have shown an association with mortality. Anxiety disorders in late life occur more often for women. We talked about that earlier. A higher risk of anxiety disorders is present for people who are single, divorced, or separated. Also higher for those who've had stressful life events, either in older adulthood or even in childhood or younger adulthood. Lower education is a risk factor for anxiety disorders in late life, as are a number of health issues. There are a number of developmental transitions that can be precipitants for anxiety in older people. Role changes, some people get more anxious after they retire. Some become more anxious when there's a change in their financial resources. When there are social interpersonal changes, again, they have to either stop seeing coworkers or they have to move away from friends and relocate. Those can be tremendous transitions and extremely anxiety provoking. Normal changes in cognitive and physical abilities, as well as other health challenges, can create anxiety. And becoming a caregiver or needing a caregiver is anxiety provoking. Grief and loss and end-of-life care also can be risk factors for anxiety, not just depression. Those of us who study and think about anxiety talk about 4 kinds of symptoms that are important to look for. We've been talking a lot about mood or emotions. Are you anxious, nervous, worried, fearful? Do you fret? Are you concerned, etc.? Associated with that, though, are what people say to themselves. What are their thoughts? People with anxiety often have what-if thoughts. The what if I get COVID? What if I have an accident? What if I have to move out of my home? The what if precedes some kind of anticipated negative event. Physical symptoms, we've been talking a little bit about that, also are part of the anxiety experience. Restlessness, racing heart, shortness of breath, muscle tension, sleep problems, appetite change. All of these can be associated with anxiety. And so if people aren't even able to say that they feel anxious, but they're having some of these symptoms, can be useful to assess a little more thoroughly. There are a couple of kinds of behaviors that are common for people who are anxious. If you think about something you're anxious about, I would guess that you would feel like you'd prefer to avoid it or you'd prefer to put it off. Older adults also, if they're worried about money, they may stop balancing their checkbook, they may not want to open their mail. They may stop going places or doing activities that cause them anxiety. Another common behavior is something we call kind of doing too much. Repetitive questions or repetitive checking in with other people, checking in with adult children to make sure they're okay, checking in with a spouse to make sure there's nothing to worry about. Repetitive snacking, smoking, and drinking also can be associated with anxiety. We've mentioned the overlap between anxiety and medical comorbidity, and this is an important issue to consider when a person is being seen in particularly a primary care setting. Assessing and managing anxiety symptoms may be complicated by medical issues that cause similar symptoms. So difficulty breathing, GI problems, pain can be symptoms of anxiety, but can also be symptoms of medical illnesses. Medical conditions can increase anxiety. So if I'm diagnosed with CHF or COPD, I'm going to get anxious about that. What does that mean for me, and what are the outcomes going to be? So the medical condition can increase anxiety, can have overlapping symptoms, and we know that at least 80% of older adults have at least one or more medical conditions, which is associated with higher rates of anxiety disorders. The presence of a medical condition, though, that creates anxiety or anxiety-like symptoms does not rule out the notion that the anxiety also includes some unrelated symptoms that require treatment. For example, heart palpitations in a patient with cardiac disease could reflect both the disease and anxiety about the disease or another topic. So this is an important differential to be aware of. There's a lot of overlap between anxiety and depression in people of all ages, but also among older people. So anxiety disorders in older adults occur often alongside major depression, substance use. As we mentioned earlier, when that is the case, the anxiety often predated the depression and increased the risk for depression. Coexistent depression along with anxiety leads to higher severity of anxiety, more severe worry, and a greater risk for suicidal ideation, which also is an issue for anxiety patients, not just for depressed patients. Those individuals, older adults that we see with depression and anxiety coexisting, probably will need more time to respond to treatment. Let's now turn to a quick review of some of the common anxiety disorders in older adults and the DSM criteria that go along with these. We mentioned very early in the talk diagnosis of generalized anxiety disorder, or GAD, in older people. GAD is characterized by excessive anxiety and worry for at least 6 months about a number of topics. We've already talked about what the common topics are for older adults to be worried about. Doesn't mean that if the person doesn't report having had the symptoms for 6 months and doesn't have what we might consider a number of different topics, that treatment isn't warranted. But the diagnosis requires this. Diagnosis also requires multiple physical symptoms associated with the worry and interference in life function due to the worry or the anxiety. Just as an aside, interesting notion that there is a bimodal distribution of onset for GAD. A very high percentage of older adults have lifelong worry that, as they may say, I've had all my life, that was there from when they were a kid or a very young adult. Another half, though, have onset after 50 years of age. So there's kind of there's two subsets of older people, some who have experienced it all their lives and some who have experienced it only more recently in older adulthood. Here are some screening questions that you can ask to decide if you think your patient is experiencing GAD. Are you a worrier? And remember, substituting other words for worry. If the person denies worry but has another word to use to describe a similar thing. Is it hard to stop the worrying or the fretting or the being concerned? Have you been feeling nervous, anxious, or on edge? Have you been feeling stressed? Does worrying, or whatever word, feeling nervous interfere with your sleep? And does your worry cause headaches, body aches, or tension? If there are any of these symptoms, more assessment is warranted, and we'll talk about some more of that in part 2. Specific phobia is also common in older adults. Specific phobia is a marked fear and avoidance of a specific object or a situation. Fear of heights, fear of driving, fear of spiders. Older people experience all of those, but they are more likely to experience fears of natural environment, events, lightning, heights, hurricanes, storms than younger people. Fear of falling is not mentioned in the DSM, but is a significant specific phobia that really needs to be queried for all older adults. It's more prevalent in women, it increases with age, but it can lead to significant activity restriction and negative impact on social, physical, cognitive functioning, can lead to a lot of difficulties with independence, increases in prevalence up to 92% for those who've had a prior fall. So once an older adult has a fall, they're going to be afraid of falling again. And this fear of falling can actually impede rehab and require treatment. And there are some good treatment programs for fear of falling. Screening questions here. Do you fear anything specifically, such as falling, storms, or heights? And do you avoid being in any kind of situations where you might encounter these? Although panic disorder is not highly prevalent in older people, it is important for primary care providers to be cognizant of, because this kind of symptom may easily bring a patient to a PCP office. Panic disorder is characterized by recurrent, unexpected panic attacks leading to some kind of maladaptive behavior change. And detection of this in older people may be complicated by cognitive difficulties and medical conditions like COPD that induce panic-like symptoms. Certainly stressful life events in older adult or even losses can promote and maintain panic attacks and panic disorder. The kind of question you might ask here is, do you have a sudden overwhelming body anxiety with shortness of breath, sweating, or tightness in your chest that lasts several minutes? I think most people are familiar with the diagnosis of PTSD, but it is a common problem for older adults, some of whom have experienced trauma in late life, and others who are either still or newly experiencing reactions from stressors that occurred earlier in their lives. PTSD requires exposure to an actual or threatened death, serious injury, or sexual violence, with intrusive memories like flashbacks, nightmares, and avoidance symptoms. So again, we hear this avoidance. Anxiety. Avoidance is so common in anxiety. People with PTSD avoid situations, activities that trigger the memories about the traumatic event. Cognitive impairment, again, can increase PTSD symptoms and kind of ruminating about past traumas. And again, the stressful life event can be something that the older person experienced in aging, but it also can be, PTSD can be a reaction to earlier traumatic experiences. There are reports of, for example, older adults who served in World War II, who came back from the war, functioned well, didn't have any symptoms, then retired and all of a sudden started having PTSD symptoms. So once they didn't have work to help them avoid thinking about the trauma, they then started having PTSD symptoms. So, screening question, do you have anxiety related to any kind of trauma, causing you to have nightmares or to avoid any reminders? Last topic for this talk is anxiety in dementia. Anxiety in dementia is a little difficult to assess, partly because of language differences and memory differences, and because there hasn't been very much research, but it is an extraordinarily important topic to address with your patients who are having cognitive impairment. Dementia symptoms occur in as many as 70%. Anxiety symptoms, occur in as many as 70% of people with dementia. Anxiety disorders occur in up to 20% of people with dementia. High rates also in people with mild cognitive impairment. I love this quote. Richard Taylor was a psychologist who lived in the Houston area, who was diagnosed with Alzheimer's, but who maintained his verbal skills for many years past what most people with Alzheimer's are able to experience. And he wrote some books and gave talks about what it was like to experience Alzheimer's and dementia. He said this in one of his books: fears of losing control, fear of what will happen tomorrow, fear of who I will become, fear of the unknown are as much or more of a problem for me in my day-to-day living than is the disease itself. How about the impact of anxiety in people with dementia? Increases burden on both the patients and their caregivers, increases behavioral problems and ADL limitations, reduces social functioning and independence, actually leads to higher rates of nursing home placement, and increases vulnerability to side effects of medications that are sometimes used to treat anxiety. We'll talk about that in part 2. Anxiety symptoms in people with dementia are broader and require looking a little beyond just asking a person how they feel. Certainly worrying, they can talk about worrying, they ruminate, they can talk about thinking a lot. You can notice that they're thinking a lot because they repeatedly ask the same question. They check in with things. You can hear sometimes the anxiety in their voice, some kind of anxiety without a clear focus for that anxiety, irritability, restlessness, poorer concentration, more hypervigilance, more tension in their muscles, aches and pains, and more sleep disturbance and fatigue are all signs that a person with dementia may be experiencing anxiety. Okay, to finish up part 1, just a couple of summary points. Please assess for anxiety. It's really important. It's there. Your patients are often experiencing it, and if we don't ask about it, we won't know, and we won't be able to help. Excessive anxiety is associated with, excessive anxiety associated with distress and interference is not a normal part of aging. Anxiety is more common than depression in older people. Even anxiety symptoms that don't meet diagnostic criteria can cause significant distress or impairment and may warrant intervention. Anxiety is highly comorbid with depression and medical illness. I'd like to thank you for joining us today for part 1 and welcome you to tune in for part 2. Know that your time is quite valuable and appreciate your commitment to providing age-friendly care for older adults. Thank you.